We'll discuss heart murmurs in a simple way. Because this topic can become heavy, I've divided it into two parts. In part 1, we'll cover the basic approach, systolic murmurs, mitral valve prolapse, and early diastolic murmurs. Don't memorize murmurs as a long list. At the bedside, use one sequence: timing, location, radiation, maneuvers, and severity clues. This pattern makes murmurs easier. Auscultation helps you suspect the lesion, but echo confirms anatomy, severity, and hemodynamic impact. First ask, is it systolic, diastolic, or continuous? Then describe shape, pitch, quality, site, and radiation. A harsh murmur, a blowing murmur, and a low-pitched rumble point toward different diagnoses. Remember, a loud murmur does not always mean severe disease. Loudness depends on turbulence, flow, and gradient. Now start with the first major systolic pattern, the ejection systolic murmur. This is crescendo-decrescendo and usually suggests outflow obstruction. On the left side, think aortic stenosis, or HOCM, causing left ventricular outflow obstruction. On the right side, think pulmonary stenosis causing right ventricular outflow obstruction. Aortic stenosis is harsh, heard at the right upper sternal border, and radiates to the carotids. HOCM is dynamic, so it gets louder when preload falls, like standing or Valsalva strain. In aortic stenosis, late peaking, soft A2, and slow rising pulse suggest advanced disease. Next, hollow systolic murmurs. These run from S1 to S2 because the pressure gradient persists through systole. Mitral regurgitation is heard at the apex and radiates to the axilla. Tricuspid regurgitation is lower left sternal edge and louder with inspiration. VSD is also near the lower left sternal edge, but is usually harsh and may have a palpable thrill. Diagnosis depends on timing, location, radiation, and bedside behavior. Now, look at mitral valve prolapse. This gives a mid-systolic click, followed by a late systolic murmur. Standing or Valsalva strain reduces left ventricular volume, so the valve prolapses earlier. The click moves earlier and the murmur becomes longer. Squatting increases filling, so the click moves later and shorter. Finally, for part 1, early diastolic murmurs. These are usually pathological and should not be ignored. Aortic regurgitation is high-pitched, blowing, and decrescendo. It is best heard with the diaphragm when the patient leans forward in end expiration. Look for wide pulse pressure, bounding pulse, and a hyperdynamic apex. Pulmonary regurgitation is usually heard at the left upper sternal area with pulmonary hypertension. That completes part 1. Watch part 2 for mid-diastolic murmurs, continuous murmurs, dynamic maneuvers, and severity clues. For better understanding, watch part 1 first, where we covered the basic approach, systolic murmurs, mitral valve prolapse, and early diastolic regurgitation murmurs. Now let's complete the picture with mid-diastolic murmurs, continuous murmurs, maneuvers, severity clues, and bedside traps. A mid-diastolic rumble usually points toward mitral or tricuspid stenosis. Mitral stenosis is best heard at the apex with the bell, especially in the left lateral position. An opening snap may be present when the valve is still mobile. Important pearl: pre-systolic accentuation is due to atrial contraction, so it disappears in atrial fibrillation. Also remember Austin-Flint murmur. Severe aortic regurgitation can produce an apical mid-diastolic murmur and mimic mitral stenosis. A continuous murmur begins in systole and continues through S2 into diastole. The classic example is PDA, producing a machinery-type murmur near the left infraclavicular or upper left sternal area. But don't label every continuous murmur as PDA. AV fistulas, surgical shunts, and other vascular communications can also cause continuous murmurs. Now the maneuvers. Inspiration increases venous return to the right heart, so right-sided murmurs, especially tricuspid regurgitation and tricuspid stenosis, become louder. Hand grip increases afterload, so mitral regurgitation and aortic regurgitation become louder, while HOCM usually becomes softer. Standing or Valsalva strain reduces preload, so HOCM becomes louder and MVP clicks earlier. Squatting increases filling, so HOCM becomes softer and MVP moves later. Next, don't just name the murmur. Assess severity. Severe aortic stenosis may have a late peaking murmur, soft or absent, A2, narrow pulse pressure, and a slow rising pulse. Severe mitral regurgitation may have S3, a displaced apex, and volume overload signs. Severe aortic regurgitation gives wide pulse pressure, bounding pulse, and a hyperdynamic apex. Severe mitral stenosis may present with atrial fibrillation, pulmonary hypertension, or right-sided failure. Finally, avoid traps. Loud does not always mean severe, and severe lesions can sound deceptively soft, especially in low-output states. Diastolic murmurs are usually abnormal until proven otherwise. Not every murmur is structural. Anemia, pregnancy, fever, and thyrotoxicosis can produce innocent flow murmurs. Final pattern. Aortic stenosis is ejection systolic with carotid radiation. Mitral regurgitation is pansystolic to the axilla. Aortic regurgitation is early diastolic and best heard leaning forward. Mitral stenosis is a mid-diastolic rumble, sometimes with an opening snap. HOCM gets louder with Valsalva strain. PDA is continuous. Auscultation narrows the diagnosis. Echo defines severity and hemodynamic impact.